This episode is brought to you by Coffee Mate. After watching this season of the HBO's original series, The White Lotus, this is the tropical getaway I needed. One more pina colada, please.
Hey, you're not on mute.
Oh, I thought I was in paradise. Turns out it was my Coffee Mate. Coffee Mate pina colada and Thai-iced coffee-flavored creamers. Inspired by the newest season of HBO's original series, The White Lotus. For the love of coffee. Try now.
Hi everyone, I'm Barbara and this is Age Better. Today we're diving into something that could be a crucial missing piece in understanding your heart health. A test called Lipoprotein A, or LPA for short. If you've ever wondered why some people develop heart disease despite having normal cholesterol levels, or if early heart problems run in your family, this episode could be a game changer for you. I'm thrilled to welcome back Dr. Marie Navar from UT Southwestern Medical Center, who is at the forefront of cardiovascular research and a leading expert on advanced lipid testing and preventive cardiology. Dr. Navar joined me a few months ago on Age Better, where we had a fascinating discussion about the ApoB test, which is very different than the one we're talking about today. There will be a link to that episode in the show notes in case you missed it. Today, she's going to help us understand everything you need to know about LPA, what it is, why it matters, and most importantly, what you can actually do about it if your levels are high. By the end of this episode, you'll have actionable steps you can take to better understand your heart health, including how to discuss LPA testing with your healthcare provider, and lots more. You'll find detailed information about Dr. Navar's work and research in the show notes, along with a lot of other good stuff. Remember, Age Better is all about you and all about giving you the knowledge you need to make informed decisions about your own health. If you have ideas for future episodes or topics you'd like me to cover on the show, please reach out to me. Please reach out to me at agebetterpodcast@gmail.com or on social media. Okay, everyone, get ready to age better. Hello, Dr. Navar, and thank you so much for coming back to Age Better.
Oh, thanks for having me, Barbara. I'm so happy to be back.
So when you were here last time, a few months ago, we talked about the ApoB test, which is a test a lot of people don't know about. But thanks to you and you're taking the deep dive with me, a lot more people know about it now, including me. And in fact, a few weeks afterward, I had my annual physical and I made sure that I had that test, as well as the test that we're talking about today, which is the LPA test. So we should get right into that. Okay, so let's take it right from the top. What is lipoprotein A, the LPA test? What is it and how is it different from the LDL cholesterol?
Well, thanks, Barbara. And it's perhaps the most important question you're asking because even most doctors don't know what LPA is. And in fact, most cardiologists do not routinely measure LPA. So lipoprotein A, we abbreviate LPA, or sometimes you'll hear it Lp(a), is a type of cholesterol particle that floats around in our bloodstream, but isn't picked up by the traditional lipid panel. So the traditional lipid panel measures good cholesterol. Those are the particles of cholesterol that are traveling in our bloodstream, bringing cholesterol back from our tissues to be eliminated through our liver, and bad cholesterol particles. And those particles are the LDL particles, the IDL, and the VLDL particles. Those are the particles that carry cholesterol and can deposit cholesterol into our artery walls, causing heart disease, peripheral arterial disease, and stroke. So most of the bad cholesterol is floating around in our body in lipoproteins, which are little meatballs that have cholesterol and triglycerides on the inside and a single ApoB protein on the outside. So there's little particles with lipids and protein, hence the word lipoprotein. So LDL is the most common form of that particle in the body. But there's another type of particle that's LPA, which is essentially an LDL particle that has an extra protein attached to it. And that protein's called ApoA. And when you attach this extra protein onto an LDL particle, it makes this particle sort of supercharged in the sense that it becomes a lot more dangerous on a per particle level to our vessel walls. So these particles are more likely to get trapped in the artery walls and leave cholesterol behind. And they also probably have some additional dangerous effects, like promoting the formation of blood clots. Those are not good. That's how a heart attack happens or a stroke. And so these particles are like an LDL particle, but have an extra protein on them that makes them even more dangerous. But we don't know what our levels of LPA are if we don't measure it directly, because you can't pick it up from the regular lipid profile that we would get checked.
So it's clearly more dangerous, or it's as dangerous as, say, a high LDL level, correct?
Correct. So particle for particle, they're actually more dangerous.
Mm-hmm.
But we have fewer LPA particles than LDL particles. So there's a little bit of a balance. It's sort of comparing apples to oranges a little bit. But if your LPA levels are high, then your risk of heart disease will be elevated, even if all of your other risk factors are controlled. And what makes LPA really interesting is that unlike LDL cholesterol, for which we can lose weight, change our diet, exercise, our hormones affected a lot, LPA is actually fairly stable over our lifetime. And in fact, we reach what our adult LPA levels are going to be in our early teenage years. So if somebody has a high LPA at the age of 40, it's been high already for almost 3 decades. And because of that, when someone has a high LPA and they've had it high for a long time, it causes a lot more cumulative damage early in life. And it's actually one of the leading causes of premature heart disease. So heart attacks or strokes in people in their 50s or even 40s or 30s sometimes.
No, that's incredible. And why is it not tested on a regular basis the way the normal lipid panel is tested? Why is that?
There's some interesting history here. So the first is that it's only more recently that we've started to really understand a lot about the role of LPA, what's high, how important is it, and does it add in terms of how we would manage somebody to everything else. So doctors don't like doing tests that don't change how we manage patients.
Mm.
And it's also hard to do a test for something that we don't have a treatment for. So to say, oh, you have high LPA, but I don't have any medications to lower your LPA right now, what's the point of testing? So historically, there has not been a recommendation to measure it because we hadn't done the studies to show that it sort of adds to other risk factors on a population level and finding out who's at high risk and who's not. And we also haven't had any therapies to change it. But that's shifting, and it's shifting right now. And so there's a lot of movement to start to increase measurement of LPA, because we think as soon as maybe even 2026, we'll have drugs that can lower LPA and potentially then reduce the risk of heart attack and stroke.
That's incredible. And that's a real game changer. And you did reference that when you were on the show a few months ago talking about the ApoB test. You did say that you are, in fact, working on some projects in that direction. And so that's very, very exciting. And in fact, I said you should definitely come back and talk about that when you're ready to talk about that. But this is the LPA levels that we have are primarily genetic. And you did just say that they probably peak when we're teenagers. So is it due to genetics and lifestyle, or really strictly genetics?
It's almost entirely genetics.
Mm-hmm.
The almost asterisk is actually relevant to us because LPA levels do go up a little bit in women around menopause. Yet another gift to people who go through menopause,
to the list.
yet another thing to add to the list of 2 thumbs down. But for the most part, it's almost entirely genetically determined, and it's fairly stable. Now, you're not going to get the exact same level if you measure it twice in the same person. But from a qualitative standpoint, if your LPA level is 10, it's going to be low forever. If it's 300, it's going to be high forever, but there's some measurement error sort of within the range of high versus low.
So who should consider getting tested for LPA? Like I just said earlier, I did get tested for LPA. I do have a genetic component. My mother had heart failure and AFib, and she had some other heart issues. So, I thought maybe I would have that genetic disposition. Turned out that my number was actually very good, and I'm happy to report that. But who should get the LPA? Should everybody get it because we just don't know?
Well, I'll tell you what the guidelines say, and then I'll tell you what I do because they're a little bit different.
Right.
The American Heart Association, American College of Cardiology guidelines have to date recommended LPA testing in people with their own history of or a family history of premature cardiovascular disease, and specifically atherosclerotic disease. So not heart failure or rhythm problems, but people who've had a heart attack or stroke. In men before the age of 55 and women before the age of 65, we call premature. So people with a family history of young people having heart attacks and strokes, or people who themselves have had heart attack or stroke at a young age, are the group that it's most commonly found in. And so that's been the group that we think is probably the highest yield for testing. My practice, and the Europeans actually now have expanded their guidelines to recommend universal testing one time in everybody's life.
Mm-hmm.
So it's easy to do. It's not affected by fasting. It's a simple blood test. And once you've had it measured once, you don't need it checked again because it doesn't really change. So if we measure it, we can identify people who have really high levels of LPA. Now, I told you a minute ago that we don't have any drugs to treat it. So what's the point? But the other thing that we've learned with research in the last 10 years is that even if we can't lower LPA, if we treat your other risk factors really aggressively, we can sort of offset that risk.
Right. That makes total sense to me. That's the reason why I decided to get tested for it. It really made sense to me. And also I could imagine if someone had the calcium score test, the CAC test, the CAC test, and it showed some level of plaque buildup, I would think that they should absolutely get that test. Also, I just think everybody should get that test. That's how I feel about it, everyone. Just get it.
I agree. It's good information.
Yes.
When I have people who have an elevated LPA level, I will usually recommend lowering their ApoB or their LDL cholesterol even more than what I would have otherwise.
Mm-hmm.
So if I have somebody who had prior heart attack or stroke, normally I'd want their ApoB less than 55. If their LPA is high, I push it into the 30s. If somebody has no other risk factors, normally I would want an ApoB and an LDL cholesterol less than 100. But if the LPA is high, I'm pushing less than 70.
Let's talk about those numbers. What is considered high for LPA?
It's interesting. For LDL cholesterol, if you look at the distribution in the population, it's like a normal distribution. You have some very low, some very high, but sort of most people sort of in the middle of a bell curve. But LPA doesn't look like that. It actually looks like a big spike, a big lump kind of close to zero, and then this long tail at the higher ends. So most people have very low LPA levels, like less than 20.
Less than 20.
Some people have undetectable LPA levels. You don't need LPA. But then above that, we start to see an increasing risk with increasing levels. So there's not like a magic number. If it's 80, it's high. If it's not, it's whatever. But it's kind of a continuous scale. And we start to think about, I think, sort of a increased risk around 125 nanomoles per liter. The clinical trials are studying people who have a LPA of either 175 or 200 nanomoles per liter.
Mm-hmm.
And there's a very small group of people, less than 1% of the population, who have extremely high LPA levels, like 400 nanomoles per liter. That population is actually pretty special in the sense that they are at uniquely high risk. And there actually is one therapy for high LPA called apheresis, where you actually get hooked up to a machine. It like pulls the particles out of your body.
Wow.
And so some centers will do apheresis for people with the most extremely high LPA levels.
Mm-hmm.
Let me just make one comment on the units as well.
Yes.
There's actually two different ways to measure LPA. We can count the particles and give you a concentration. That's usually in nanomoles per liter. That's considered the most accurate way to do it, and most labs are moving towards that. But some labs are still doing a weight-based analysis where you get a result in milligrams per liter rather than nanomoles, or milligrams per deciliter rather than nanomoles per liter. The conversion is about 2.5. So if you take nanomoles and divide it by 2.5, you get milligrams, or vice versa. So the cutoffs that I'm using are all nanomoles because that's where most of the field is moving.
Got it. Okay. So as we said, the last time you were on the show, you talked about the ApoB test. So how do the ApoB test and the LPA test relate to each other? Or do they even?
100% they do. The ApoB measures the number of all particles in our body that have an ApoB molecule on them. So that includes LDL cholesterol particles, VLDL cholesterol particles, the in-between ones of those, which we call IDL particles, and LPA particles. So it measures all of them. For the most part, it reflects mostly the number of LDL particles because in most people, the vast majority numerically of particles that we have is LDL. Even in people with a high LPA, they still have, those guys are still outnumbered by LDL and VLDL particles in most people.
Mm-hmm.
But sometimes people may have an ApoB and they've taken, they're on statins, they're on medications to lower their LDL and their ApoB, and their LDL is really low, but their ApoB still is a little bit high. And those are that can sometimes be a clue that maybe you have a high LPA, but generally speaking, you can't kind of estimate from the ApoB if your LPA is high or not, because it makes up such a small fraction of the overall number of ApoB containing lipoproteins that we have.
Right.
So I see these tests as complementary. ApoB measures the number of all of the bad for you particles. LPA measures the number of supercharged particles within that group.
Well, thank you for that. And you did say that currently there are no treatments available, and really lifestyle is not going to change that particular number because it's genetic and it kind of stays stable throughout your life unless there is some medication that we can take down the road to change that number. So you did mention maybe in 2026 or so. What are you seeing and what are you hoping for?
So the development landscape is really exciting.
Mm-hmm.
There are 3 different LPA lowering drugs that are currently being tested in cardiovascular outcomes trials. These are the studies where we sort of give half of people drug and half of people placebo and see if we're preventing heart attacks and strokes, which is the goal for this whole thing.
Yes.
The first drug that's being tested is a drug called pelacarsen. It's being studied in a trial that's called Horizon. And the anticipated end of that trial is now 2026. So we should have results from that study in 2026. And then if it's positive, I suspect we'll see drug come to market fairly expeditiously after that. But there's a lot of regulatory things and a lot of moving parts to get there. But that study is only in people who have existing heart disease. So people who've had a prior heart attack or stroke.
Mm-hmm.
The next drug that's being studied is a drug called olpasiran. It's being studied in a trial called Oceana, and that's a little bit farther behind. That drug is cool because it's given more intermittently. All of these drugs are injectable therapies, but they have different frequency of dosing. So that trial is going to be next. And then the third trial that's happening is the trial that I'm fortunate to be the global principal investigator for, and that's a medication called lepodisiran, this trial is actually enrolling people who have prior heart attack and stroke, but also people who do not. So we're studying it in
who have a certain threshold?
Bigger population.
Like a certain number of LPA?
Correct. So the first studies are all in people with fairly high LPA. So we're looking at people with a cutoff of 175 or more.
Mm-hmm.
That trial is still enrolling. So there may be people in your audience who have an LPA over 175. There's an age minimum for that trial and you have to have other risk factors for heart disease, perhaps we can put in your show notes a link to the clinicaltrials.gov website for the trial where people can learn about it. And then if they're interested in participating, see if there's a site close to them that they could reach out to.
Absolutely. Thank you for that. Yeah. And so let's just say someone goes and they listen to this episode and say, I'm getting that test, as I did, and the number is high. So, I'm assuming that they'll be guided by their cardiologist or PCP. But what recommendation do you have? I mean, should they change their lifestyle? I mean, it's tricky until some medication comes down the pike, right?
So the first thing I would say is deep breath. These are not like ticking time bombs causing heart attacks and strokes tomorrow. This is something that if it's high today, it's been high for decades and it will stay high, but it's not too late to start doing other preventive things. So the first thing I would recommend is if anybody's doing anything to make their risk worse, like smoking, go ahead and stop that. Regular exercise, heart healthy diet. And then I recommend in somebody with a high LPA to get the LDL as low as possible.
Right.
And so it's almost always going to require medication therapy there. But we know that these medications that lower LDL cholesterol can prevent heart attacks and strokes in people who have high LPA.
Right.
So we try to offset the risk with as much
intervention in other ways as possible.
But there's a couple of other recommendations. One that you mentioned, which is a CAC test. So if your LPA is high and you're over about the age of 45, it may be useful to get a coronary artery calcium score to see how much cholesterol you may have already started depositing in your artery walls, to give you an idea of sort of how far along the path are you. If your CAC score is 0, you've got a lot of time still to make good changes and prevent that. If you have a high CAC score, it's not too late, but you may think about even more aggressive things from a heart standpoint. Like if you have diabetes, there's certain medications in diabetes that are especially good to help prevent heart attacks and strokes. Some people with a lot of coronary calcium are recommended to take aspirin. I'm not giving medical advice to your audience, but there are other things that we talk about in people who have high coronary artery calcium scores. And LPA may be somewhat prothrombotic, and there's some evidence that people with LPA may benefit a little bit more from aspirin, although that data is a little bit thin. So I wouldn't overinterpret it. But I think the calcium score can sort of help people figure out how much has the LPA contributed to their heart so far. And then the other benefit for that is that if people have a lot of coronary calcium, that they have a diagnosis of coronary artery disease, they may actually then be more likely to qualify for these new therapies when they come out.
When they come out, absolutely. I just am a big believer in taking these tests and getting these tests at least once. As you said, the LPA, certainly the ApoB for sure, and then getting the CAC score as well, this calcium score test, as I did. And I was actually shocked when I got it last year because I am a runner. I eat really well. I think I lead a very healthy lifestyle. And it was 18. And you can have 0, as you know, Dr. Navar. It can be 0 in midlife. It doesn't have to be a number.
It can't. It should be 0. But
it should be 0.
I hope somebody told you that people who are endurance athletes often have higher coronary calcium scores than people who are.
Actually, no one shared that with me. So thank you for thank you very much for it. That makes me feel better. I was shocked and I wasn't so happy about it. But had those other numbers, the ApoB and the LPA, if they had not been good, then I would be really concerned right now. But I'm doing well and continue my activities.
I can't help but mention there is 2 other things. One is that if somebody's LPA is high, there's a 50-50 chance that first-degree relatives are also high. So kids and siblings and parents should also have theirs measured. It's totally genetically determined, and it's a coin flip. If the parent's high, their kids are going to have it high too. So it's a pretty and it's easy for people to get. Right now, the Family Heart Foundation is offering free at-home LPA testing. If people go to, I think the website's cholesterolconnect, either .org or .com. Maybe we could also link to that in the show notes.
I'm definitely going to link to that because when you were talking before about the genetic connection and how it's kind of, we know what the numbers are even when we're young. I was thinking, of course, of my own two daughters. I mean, my husband's not been tested and he should be. His father passed away of a heart attack at the age of 49. So he should definitely be tested.
For sure.
But he hates being dragged off to these tests like I always make him do. But that's next on the horizon for him. And then I think I will have my daughters be tested. Like, absolutely. Why not? We should know what their risk is.
Well, if your LPA is normal and
mine is.
And their father's LPA is normal, then they don't need it checked.
Right. Okay. No. So we'll go with my husband first.
I would start with him.
Okay.
If the program is still ongoing, you can get a kit sent to your house.
Thank you for that.
The other thing, though, that I'll mention, and I do recommend a lot of CAC scoring, but every test we do has potential downsides.
Mm-hmm.
There are certain people who have had bad experiences from a CAC score. So airplane pilots, for example, that have coronary calcium have a lot additional kind of things that they need done every year to make sure that they can still fly airplanes, which ends up being a lot of harangue for them without much medical benefit. If you're planning on taking out a life insurance policy, probably want to get that done before you get a CAC score, because if you have a CAC score that has a lot of plaque buildup, then that could affect your insurance as well. And then, sometimes people get nervous once they know that it's there. And I've had a few people who it's just made them a lot more worried rather than motivated. So I would make sure going into the test that if that knowledge is going to be motivating for you in a good way, great. But it's also not a get out of jail free card. If your CAC score is 0, your LPA is normal, that doesn't mean you can start smoking and eating junk food every night. It means you're doing well and to keep doing what you've been doing.
Yes. Thank you so much for that. Very, very good advice. Before I let you go, Dr. Navar, and thank you again for joining me, do you have 3 takeaways you want to make sure everyone really remembers from this conversation today?
Yes. I would say the first takeaway is I think everybody should have an LPA measured, especially those with a family history of early heart attack and stroke. Mm-hmm. The other group I didn't mention, but I would be remiss not to, are people with a higher proportion of African ancestry are more likely to have a higher LPA. So there is some genetic variability around the world in LPA levels as well. So for any Black listeners, even more important as it's more common in that population, sort of the global diaspora. So that's number 1. Number 2 is if your LPA is high, don't despair. Lots of things are available to lower your long-term risk of heart attack and stroke, and therapies to lower LPA are on the horizon. We are just on the cusp, I hope, of a lot of scientific breakthrough there. And 3, I would say, stay tuned. The science is just moving so fast.
Really?
And our primary care doctors are absolutely overburdened with the number of things that they are expected to learn about and stay on top of and know. And even cardiologists don't all know about LPA. So if you go to your doctor and talk about LPA and they're like, I don't know what you're talking about, it doesn't mean you have a bad doctor. This really is like moving so quickly. We are trying to get everybody caught up, but there will be patients that are ahead of the science from doctors for a while because these parts are moving so quickly. So it can actually be helpful when patients go to their doctors to talk about this, because then the docs say, oh, I probably should learn about this.
Yeah.
So just a reassurance, if your doctor is not very familiar with it, it's more of a reflection of the state of LPA and not a reflection of the quality of your provider.
And then what about if your doctor says, oh, I don't think you need it? Doesn't quite poo-poo you, but just, nah, you don't really need that kind of thing. I mean, my doctor was a little bit like that. Like, I don't think you really need to have but I said, these are the tests I want. I came in with a piece of paper. These are the ones I want. So I would also propose that people advocate for themselves and get the test if they feel they want the test. Am I right?
I think so. And I think
to a certain point.
providers may be reluctant to order a test that they don't know what to do with it. And so you can say, it's okay if it's high. I will find a doctor to help me take care of it so that they don't feel like they're ordering a test that they don't have something to do for you. You can say, if it's high, I'll find a cardiologist or I'll find a preventive medicine doctor who I can meet with and talk about this.
Mm-hmm.
The other thing, it may be that some providers worry that it may not be covered by insurance. Every once in a while, I get somebody whose insurance kicks it back. Now, I have a great office staff who help me write appeal letters to get those overturned, but most doctors' offices are just totally overwhelmed with those types of appeals. So I think you should be prepared to potentially pay out of pocket. And if your doctor gives you some pushback about ordering it, you can say, look, if insurance doesn't cover it, I'll pay for it out of pocket.
Mm-hmm.
And if their lab doesn't do it, you can get it done at any Quest or LabCorp. So we send these orders all the time to Quest or LabCorp, and people go to their local lab to get it done.
Mm-hmm. Mm-hmm. I think the bottom line is the more information, everyone, that you have about the health of your heart, the more prepared you'll be. I think you'll be better equipped to make the right decisions for yourself as you go forward in partnership with your trusted healthcare provider. That is the ideal. Dr. Navar, thank you so much. Best of luck with the research that you're doing and with these new medications that you're involved with. And we're really looking forward to having you come back on and talk about what's next and what's new so that we can be heart healthy and age better. Thank you so much.
Thank you so much, Barbara, and happy Heart Month to you.
Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this: we can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.